Okay, students, continuing the topic, there is reoccurrence very common in toxic megacolon. Toxic megacolon is a clinical feature of ulcerative colitis. We will discuss that in the topic. So, come to the microscopy of Crohn's disease. What we see on microscope is, if we take a biopsy of a patient of a Crohn's disease, what we see is there is neutrophil enrichment, that is in crypts of Lieberkühn. We all know that there are crypts of Lieberkühn in the small intestine. There is neutrophilic infiltration, that are termed as crypt abscesses. There is repeated destruction and regeneration leads to the distortion of mucosal architecture, which means that there is inflammation going on a specific area, and then there is regeneration of that epithelium, and all the cells are regenerating. So the continuous distortion and destruction will lead to the changes in the mucosal architecture. It will also cause pseudopyloric metaplasia. It is a very important point, which means that pseudopyloric metaplasia means that the normal intestinal epithelium is columnar with goblet cells, right? So in pseudopyloric metaplasia is that there will be lining of pyloric. Pyloric is the region of stomach. So the lining epithelium of intestinal will change to pseudopyloric epithelium, which means that pseudopyloric metaplasia. I hope it's all clear now. There is also a feature that is non-caseating granuloma. The granulomas are formed, lymphoid aggregates are formed, so granulomas appear. These are all seen on microscopy. So coming to the next part is symptoms. So what are the signs and symptoms of Crohn's disease? Is that there is we all know that ileocecal valve, ileum or colon sometimes is involved. So the pain will be on right lower quadrant. There may be fever due to continuous inflammation and all the factors. There is non-bloody diarrhea, which is a very important feature, non-bloody diarrhea. Similarly, malabsorption of fats and vitamins, because the reason behind this is that all the absorption takes place at terminal ileum. So there will be B12 deficiency, iron deficiency, and as there is also alteration in the normal mucosa of the intestine, enterocytes are loss of protein, losing enteropathy occurs, which lead to hypoalbuminemia. Remember all these signs and symptoms. Similarly, there is cholelithiasis, because we all know that the bile salts are absorbed from the small intestine, right? From the biliary tract that enters into the duodenum from ampulla of water, right? So this malabsorption will lead to the cholelithiasis. Similarly, nephrolithiasis, there will be calcium oxalate stones. So this will all lead to the this all happens in the Crohn's disease. There are some extra intestinal manifestations as well. These are very important, that is uveitis, ankylosing spondylitis, polyarthritis, joints are involved. Similarly, clubbing of fingertips, this means that the nails that are normal is seen. So in the patients of Crohn's disease, there is slight clubbing, which means that the angle between the nail bed and the skin is changed, and there is clubbing of fingers. So there is erythema nodosum. Lesions can be seen on which means that lesions can be seen on forearm and sole, etc. So and the very important point is smoking. Smoking is a major risk factor in Crohn's disease. So patients of Crohn's disease should avoid smoking. Now come to the diagnosis. How we will diagnose the patient of Crohn's disease? He will come up with these signs and symptoms. So what we will do is endoscopy. Endoscopy is actually a camera that is taken inside either through the mouth, oral cavity, and deep down through the upper GI. And in case of we want to see the small intestine, so we will do colonoscopy or sigmoidoscopy to reach the small intestine. Similarly, barium enema is given upper GI with small upper GI endoscopy is also done. So this is about diagnosis. Now come to the treatment. After diagnosis, we treat the patient with sulfasalazine and mesalazine. These are all immunosuppressants and systemic corticosteroids are anti-inflammatory, as there is the whole Crohn disease involve the complex interaction of immune responses. There are exaggerated responses, so we will give immunosuppressants like azathioprine, 6-mercaptopurine, and we all know that in the treatment, if the patient is having bile salts accumulation, that is bile stones, so we will give cholestyramine, that is also a anti lipidemia drug. So comes to the surgical intervention. There is segmental. The affected part of the intestine is resected. So this is all about the Crohn's disease. I hope you all got my points from the Crohn's disease, and it will be easy for you to diagnose. We will soon be discussing the scenarios of all these diseases as well. Now discuss the ulcerative colitis. The location of ulcerative colitis is rectum and sigmoid. So it is briefly termed as proctitis or sigmoproctitis. Okay, ulcerative proctosigmoiditis. Ulcerative mean ulcerations there are, and colitis mean colon involving. So rectum is 100% involved, always involved in the patient of ulcerative colitis. Sigmoid is involved in briefly, sometimes colon is also involved. Now come to the next points, that is distribution. Distribution is diffused. As I'm showing you in this picture of medium Robbins, that ulcerative colitis, there is diffuse. This is sigmoid and rectum, and small part of colon is also involved. So there is diffuse inflammation. There are no skip lesions. So this is what it is trying to be said, that second is there is no common structure, as there is no marked inflammation or fibrosis, so there will be no structure formation. Inflammation is only limited to mucosa or submucosa. It is not involving the all three layers. Next is the pseudopolyps. Pseudopolyps I have told you before in the previous topic. So come to the next point, ulcer formation. Ulcer formation is superficial, not deep, because it is not involving all the three layers, so the ulcer formation is only superficial. Lymphoid tissue is moderate. Similarly, there are no fibrosis, no granulomas, no fistula formation, as there is also not marked vitamin absorption. And similarly, although malignancy is very important feature in ulcerative colitis, we should take care about the malignancy of a patient, because in ulcerative colitis there are high risk of malignancy. There is no recurrence after the surgery if one surgery is performed. Now, what is toxic megacolon? Toxic megacolon is a clinical feature of ulcerative colitis. What happens in ulcerative colitis is that it leads to the dilatation of the affected part, and there is increase in the size, and this leads to the decreased mortality, and this leads to the toxic megacolon. Similarly, seen on the microscopies, there is no serosal thickening, or surface is completely normal. Mural thickening is absent, as there is only superficial layer involved. So all the factors involving in ulcerative colitis are absent in Crohn disease is absent in ulcerative colitis. Similarly, let's discuss the symptoms of ulcerative colitis. Is that there are this is a very important feature, that there is abdominal cramps that are relieved by defecation. Once the person defecates, there will be no cramping in the body. So asking a patient, it is a very important question, that cramps are present or not, or they are relieved by defecation or not. Also, there is expulsion of stingy mucoid material, which means that the mucoid or feces will be very mucoid type, and mucoid means that thickies, mucus containing material. Similarly, this is a very important feature, that there will be hematochezia, which means that fresh blood in the stools. Tenesmus is a very important feature, that means rectal dry heaves will be accumulating. and leading to the tenesmus, hematochezia. There is a very important feature that now we should rule out ulcerative colitis with the infective diarrhea, because in infective diarrhea there is fresh blood in the feces, so it is important to rule out infectious diarrhea. So now come to the extraintestinal manifestations that are same as that of Crohn's disease, but one point that is different is primary sclerosing cholangitis, that we will discuss in the liver. This is inflammation of biliary tract. So there is also sclerosing cholangitis, pericholangitis. In this ulcerative colitis, smoking protects ulcerative colitis. The mechanism is unknown, but there are certain factors that lead to the protection of ulcerative colitis. Now come to the diagnosis of ulcerative colitis is that number one is the stool culture. We will take the stool culture of the patient, a suspected person. So to rule out infectious diarrhea, there is abundant fecal leukocyte count, and WBCs also appear in the ulcerative colitis. On this behalf, we will diagnose the patient. Now treatment is same as that of Crohn's disease, that immunosuppressants are given, corticosteroids, sulfasalazine, but there is no risk of bile salts or nephrolithiasis in this patient, patient of ulcerative colitis. Surgical is same, the affected part is resected, that is colonectomy is performed, and this is all about IBD. Hope you liked my video. Please subscribe my channel and hit the bell icon, and do comment. If you guys have any query, you can ask me. I'll surely reply you. Thank you so much.